So hello guys, welcome back to a new video. So today we are going to see diabetic retinopathy. Okay, so we are divided into introduction, risk factors, local protective factors, pathogenesis, classification, management, treatment and screening. Okay, now starting with the introduction. Diabetic retinopathy means retinal changes occurring in a diabetes mellitus patient. Okay, diabetes mellitus are of two types, diabetes type 1 and type 2. In type 1 there is decreased insulin production, and in type 2 there is increased insulin resistance. Okay, because of obesity. Now what are the risk factors? Okay, duration of diabetes. In 50% of patients develop retinopathy after 10 years, 70% after 20 years, 90% of patients after 30 years. Means diabetes is a chronic disease, and as chronicity increases, the chances of getting this diabetic retinopathy increases. Okay, poor metabolic control, pregnancy, hypertension, neuropathy. Okay. Next, what are the local protective factors? Protective factors are high myopia, chorioretinal scarring, glaucoma, optic atrophy, retinitis pigmentosa. Okay, this is due to decreased retinal metabolic demand. Retina required less glucose there. Okay, now what is the pathogenesis? Okay, the most important they will ask is pathogenesis only. Firstly is microangiopathy. Okay, microangiopathy, small blood vessels. Okay, the two important seen are microvascular occlusion and microvascular leakage. Okay, first there is occlusion and another one is a leakage. Okay, here the very beautiful diagram you can see. Okay, here there is loss of pericytes. Okay, first I will this is the blood vessel. Blood vessel will be having epithelium. Okay, outside will be pericytes. Okay, pericytes will help in contraction of the blood vessel. Okay, here there is loss of pericytes, means pericytes are lost. That's why there is exudation, means fluid comes outside. Another one is like here another instruction is there. Basement membrane gets thickened and endothelial cell damage. RBC changes and platelet sticks are increased. Okay, like like athyroma type conditions. Okay, here one is the occlusion, another one is a leakage. Okay, microvascular occlusion, microvascular leakage. Leakage is because of pericytes, and occlusion is because of basement membrane thickening, endothelial cell damage, and RBC and platelet stickiness in the endothelium. Okay, after microangiopathy, next is microvascular occlusion. Here there is first is capillary changes. Capillary changes are because of loss of pericytes, thickening of the basement membrane, proliferation of endothelial cells, resulting in microaneurysms. Okay, first there is loss of pericytes. Pericytes are lost. That's why there is endothelial proliferation. The endothelium gets proliferate, and as pericytes are lost, there is microaneurysm. Okay, this ruptures and there is small microaneurysms are there. Okay, and the basement membrane get thickened. Next, hematological deformation and aggregation of RBC and platelet resulting in decreased oxygen transport. Okay, as the blood vessel get clogged with RBC and platelets, there is decreased blood supply, which leads to retinal hypoxia. Okay, retinal hypoxia result in arteriovenous shunts and IRMA. Okay, what is IRMA? Intraretinal microvascular abnormalities. Okay, IRMA shunts from the arterioles to the venules. IRMA shunts from arterioles to the venules. As there is hypoxia, because RBC and platelets are clogged the blood vessel, there is formation of IRMA, that is, and arteriovenous shunts. Okay, IRMA is intraretinal microvascular abnormalities. Next, there is neovascularization. Neovascularization is because liberation of a vascular endothelial growth factor by hypoxic retina. Okay, as there is hypoxia, the retinal cells secrete VEGF. Okay, what is VEGF? VEGF cells in neovascularization. Okay, which promotes neovascularization of the retina and optic nerve head as a consequence of retinal ischemia. Okay, another one is microvascular leakage. That is breakdown of an inner blood retinal barrier. Microaneurysm is present, and because of weakened capillaries, as loss of pericytes is there. Next is increased vascular permeability resulting in focal or diffuse retinal edema. Okay, and hard exudates are seen, may occur in a succinate pattern. Okay, hard exudates are like with sharp borders. Okay, they are lipid deposits. Classification, there are two classifications: Eva-Connors classification and ETDRS classification. Okay, Eva-Connors classification is divided into background retinopathy. Background retinopathy is also known as non-proliferative retinopathy. Next is pre-proliferative and proliferative retinopathy. Three types. Okay, now coming to ETDRS classification. ETDRS is divided into background or non-proliferative retinopathy. In that there are four: mild, moderate, severe, very severe. Another one is CSME. Okay, maculopathy with or without changes in significant macular edema. Other is the proliferative diabetic retinopathy. In that there is without high risk characteristics, with high risk characteristics. Other one is non-proliferative retinopathy. Okay, now we will read first is background or non-proliferative retinopathy. In that mild, moderate, severe and very severe. Okay, first we will deal with mild, okay, mild diabetic retinopathy, there is few microaneurysms are seen, retinal hemorrhages, hard exudates, and seen in one quadrant only, okay. There are few microaneurysms because as the blood vessel get thin, there is microaneurysms, retinal hemorrhages, hard exudates are seen in only one quadrant, okay. Next, moderate. Above features are seen in two or more quadrants, two or three quadrants. Okay, retinal hemorrhages and hard exudates. In severe pre-proliferative retinopathy, we will use 4-to-1 rule. Okay, 4-to-1 rule is 4 quadrant or hemorrhages or microaneurysms, 2 quadrant venous bleeding, and one quadrant intraretinal microvascular abnormalities. Okay. Here is a circle, we divided it into 4 quadrants, okay. 4 quadrants microhemorrhages means all 4 quadrants are microhemorrhages, and 2 quadrants venous bleeding, okay. Venous bleeding means the venous will get beaded, okay. 2 quadrants, okay, they are seen in 2 quadrants, and in one quadrant intraretinal microvascular abnormalities, okay. 4-to-1 rule. This is severe proliferative retinopathy. In very severe, it is defined as 2 or more as the above features, okay. Very severe, 2 or more of above features. First, you can, again one time classification. Background or non-proliferative is divided into mild, moderate, severe, and very severe. In mild, there is retinal hemorrhages and hard exudates seen in only one quadrant. In moderate, they are seen in 2 or 3 quadrant. In severe, we apply 4-to-1 rule. 4 quadrants of microaneurysm, 2 quadrants of venous bleeding, 1 quadrant of IRMA. Okay. In very severe, defined as 2 or more above features. Okay. Now coming to proliferative diabetic retinopathy. Proliferative diabetic retinopathy. What is proliferating here? Here, neovascularization. Blood vessels are proliferating. Okay. Here there is neovascularization of disc and neovascularization of elsewhere, okay, NVD and NVE, with or without following high risk characteristics, okay. Neovascularization of this disc, that is greater than 1/4 to 1/3 of the disc area. Any NVD, any neovascularization disc with vitreous hemorrhage, neovascularization of elsewhere with half of the disc area, okay. The same thing we will see in diagram again. Okay, this is proliferative or high risk, okay, proliferative diabetic retinopathy. Let me come finish this. Next is maculopathy. Maculopathy is clinically significant macular edema, okay, CSME, edema involved in the center of the macula. Seen in slit lamp examination of 90 D lens, there is thickening of the retina within 500 micrometer of foveal avascular zone, hard exudates with 500 microaneurysm with foveascular associated with thickening of adjacent retina, zone of retinal thickening of one disc area of the layer, any part with one disc diameter of, you see diagrams only, they are very much clear, okay. Clinically significant macular edema, there is more than one disc, within one disc diameter, there is retinal thickening, okay, within one disc diameter. Next, here you can see retinal thickening is present, that is 500 micrometer within one disc diameter, okay. Within one disc diameter, retinal thickening is present. Next, criteria 2, there is hard exudates are seen, okay. These whitish things are hard exudates within one disc diameter, okay. Next, NPDR, non-proliferative diabetic retinopathy. Here in criteria 3, there with greater than one disc diameter, along with you can see hard exudates with more than one disc diameter, okay. This is one disc diameter, and hard exudates are seen everywhere, okay. Now coming to advanced diabetic eye disease, okay. There is persistent new vessel, tractional retinal detachment, and neovascular glaucoma, okay. In advanced diabetic eye disease, there is persistent new vessel, tractional retinal detachment, and neovascular glaucoma, okay. Here we can see extensive avascular glial tissue and localized inferior retinal detachment in PDR, okay. This whitish thing. Okay, causes of visual loss are in non-proliferative diabetic retinopathy is because of macular edema or ischemia. In proliferative, it is because of tractional retinal detachment, neovascular glaucoma, or vitreous hemorrhage. Okay, in PDR, as there is neovascularization, there is a tractional retinal detachment, neovascular glaucoma, or vitreous hemorrhage. Okay, what are the differential diagnosis? Hypertensive retinopathy, retinal vein occlusion, radiation retinopathy, ocular ischemic syndrome, anemia, leukemia. Okay. What all investigation you will do in diabetic retinopathy, okay? We will do direct and indirect ophthalmoscopy. We will do slit lamp examination with 90 day lens. There we can see like criteria 1, 2, and 3, okay? That is retinal thickening and hard exudates, that only, okay? Next is, there is color fundus photography, fluorescein angiography, and optical coherence tomography, okay? Direct and indirect ophthalmoscopy, slit lamp examination 90 day lens, color fundus photography, fluorescein angiography, optical coherence tomography, OCT, okay? On fundus fluorescein angiography, you will see all eyes with maculopathy, unexplained visual loss is there, asteroid hyalosis is there. What is asteroid hyalosis? Asteroid hyalosis are nothing but degenerative changes in the vitreous. Okay, there is star shape opacities flowing like attached in the vitreous. Okay, this is seen in greater than 60 years of old age. Okay, in old age people you will see asteroid hyalosis. There is star shape degenerative opacities. Okay, next is doubtful diagnosis. Next on treatment, first control the diabetes. Next is the laser, intravitreal injection of triamcinolone, okay, steroid. Next is surgery, low visual aids, okay. Treatment of diabetic retinopathy based on the severe studies. Early treatment diabetic retinopathy, okay, ETDRS. ETDRS we will do focal laser. Focal laser decreases the visual loss of macular edema by 50%. No benefit from aspirin, okay. Next is diabetic retinopathy study, DRS. We will do pan-retinal photocoagulation, okay, which reduces the severe vision loss in high-risk PDR, okay. Next is diabetic retinopathy of vitrectomy study, DRVS. Early vitrectomy and of vitreous humerus in type 1 diabetes is advised, okay. Vitrectomy is advised. It can be deferred in type 2 diabetes. Diabetic control and complication trial. In type 1 diabetes, tight control of blood sugar decreases the progression of retinopathy and macular edema. Okay. In type 1, control of blood sugar decreases the retinopathy and macular edema. First, we should control blood sugar. HbA1c less than 8% reduces risk of retinopathy. Rapid normalization and tight control of blood sugar after a period of prolonged hyperglycemia can lead to worsen the retinopathy. Okay, if a person is having large amount of blood sugar for a prolonged period of time, when you suddenly decrease that blood sugar, there is more retinopathy seen. Okay, next is UKPDS, that is United Kingdom Prospective Diabetes Study. Tight control of blood sugar and blood pressure, slowly progression of retinopathy and development of macular edema in type 2 diabetes patient. Okay. These are the things, so once again you have to read so that you can understand it again and again. Okay, main things I will tell. One is focal lasers are used, pan-retinal photocoagulation is used, vitrectomy is used. Okay, and sudden blood sugar control should be avoided so as to prevent worsening of this retinopathy. Okay, and tight control of blood sugar and blood pressure should be taken care. Okay, control of diabetes. DCCT and DCCT for IDDM and UKPDS for non-insulin dependent diabetes mellitus. Okay, that is insulin dependent and non-insulin dependent. What are the important studies in diabetic retinopathy? In DRS we will do pan-retinal photocoagulation. In DRVS we will do pars plana vitrectomy, and in ETDRS we will do CSME. Okay, that is laser we will use. For CSME, focal lasers are used. That is argon green is preferred. Yellow laser can also be used. Next, for PDR, pan-retinal photocoagulation. Okay, pan-retinal photocoagulation. We should spare the macula and we should do pan-retinal photocoagulation everywhere. Okay, small dots are will given. Criteria for high-risk proliferative diabetic retinopathy: intravitreal injection of steroids, that is IV triamcinolone, and anti-VEGF. Okay, that is one antibody derivative is there, rivasizumab is there, that is anti-VEGF we should give so that to prevent neovascularization. Surgical treatment is vitrectomy surgery, pars plana vitrectomy, endolaser photocoagulation, release of tractional bands, okay, remove of subretinal neovascular membrane, and treatment of retinal detachment. Okay, if there is tractional retinal detachment present, we should treat it. Surgery, pars plana vitrectomy should be done. These are some steps. Okay, let me see diagram only. This is pars plana this is pan-retinal photocoagulation. Okay, and this is repair of tractional membrane, removal of tractional membrane. Okay, pan-retinal photocoagulation, you can see very beautiful. They are giving small dots. Okay, pan-retinal photocoagulation is also done for to prevent retinal detachment also. Okay. Next, diabetic retinopathy treatment guidelines are: background is to control of the diabetes and regular review should be done. Okay. There is maculopathy in CSME, focal leak and circinate retinopathy for focal photocoagulation should be done. Diffuse leak around the macula, we will use grid laser. Okay. And in pre-proliferative retinopathy, frequent review should be done. In proliferative retinopathy, that is there is, as to prevent neovascularization, we will do pan-retinal photocoagulation. In advanced diabetic eye disease, we will do vitreoretinal surgery and photocoagulation. Okay, different diseases have some kind of different treatment. Okay. There are two diabetic type 1 and type 2 diabetes. Okay, if type 1 is there, we should first examination would be done 5 years after the onset of diabetes. Okay, if there is type 2, as soon as possible we should do. Okay, because type 2 will be already present from previously, but we will come to know later. Okay, during pregnancy and women of diabetes, it should be done in first trimester. Okay, and 3 monthly review should be done. AAO is American Academy of Ophthalmologists. AADA is American Academy of Diabetes Association. Okay. Now review of patient with diabetic retinopathy. Mild NPDR, we should review in 12 months. Moderate NPDR with macular edema 6 to 12 months. Moderate NPDR with non-CSME 4 to 6 months. NPDR with CSME and PDR we should review in 3 to 4 months. Okay. Review means we should see the patient again and again. So I want you to see once again what is the classification. Okay, classification. If you remember classification, you can write what all is seen in that. Okay. See, ETDRS classification, they have divided into non-proliferative. In non-proliferative, there are mild, moderate, severe and very severe. Another one is CSME, that is clinically significant macular edema. Next is proliferative diabetic retinopathy, that is without high risk characteristics and with high risk characteristics, and non-proliferative diabetic retinopathy. Okay, proliferative, non-proliferative, and CSME. Okay, that is clinically significant macular edema. This is the diabetic retinopathy. See you all in the next video. Until then, Jai Hind, Jai Bharat. Bye bye.